Hello and welcome to Health Live at Seniors Today. We have here with us today Dr. Percy Jal Chibber, who's a well-known urologist. He's Director of Urology and Renal Transplantation at the Sir Harkishandas Reliance Foundation Hospital and Research Centre. He's also a consultant urologist at the Jaslok and Beach Candy hospitals in Mumbai. He has been visiting urology and laparoscopy specialist to the Tata Memorial Cancer Centre, and although he practices all aspects of urology, his special interests are urology, urological, laparoscopy, robotic surgery, and renal transplantation. Dr. Chibber took his undergraduate medical education, that is the MBBS, at the Nair Hospital in Mumbai, and then he did his MS in general surgery, standing first in the university, and was awarded 4 gold medals. He did his specialist training in urology at the University of Edinburgh and also obtained his fellowship at the Royal College, which is the FRCS. He returned to Mumbai and started his practice in 1981 and was soon appointed Honorary Assistant Professor of Urology at the Grant Medical College and the Sir J.J. Group of Hospitals, where he was later to hold the position of Professor and Head of the Urology and Renal Transplantation Department between 1995 and 2007. I could go on and on about Dr. Chibber, but I'm going to request him to speak to us, and then we will have questions from the audience. Some questions have already come in by mail, and we'll be happy to have them have Dr. Chibber address them. Over to you, Dr. Chibber.
Thank you very much. Right now, today I'm addressing what we consider as senior citizens. I don't know, senior citizens always somebody is older than I am. So, so you all are in good company, don't worry. What is the main problem that senior citizens have? It's usually revolves around passing urine. That's the main urinary problem they have, whether they're males or females. Today, I'm going to stress on the urinary problems in passing urine in aging males. Can I have my first slide, please? Can we share the screen? Next slide, please. Right. So now we get on to the presentation. The main anatomy that we need to concern ourselves with is the bladder. You see that the bladder has a passage out that goes through a gland, which is roughly the size and shape of a walnut, and the urine passes through the center of the walnut. Imagine that these two halves are the fruit of the walnut that you eat, and the surrounding shell is the shell of the walnut. Only the walnut has a hard shell. This shell is a bit leathery. And below that, you can see the muscles that control the passage of urine. Next slide, please. People often wonder, well, patients tell me, well, I've got a problem in the front passage. Why do you choose to put a finger up my backside? Well, this is why. Because the rectum, if you can see where the finger is, the rectum is a neighbor of the prostate. It's a posterior neighbor. That means a neighbor behind the prostate. So if I put my finger in the rectum, then I can feel your prostate from behind. And that's very, very important to get to know what is the nature of the enlargement of the prostate. Next slide, please. Well, what did the prostate do in health? It's an important gland for reproduction. What do I mean by that? The juice that you ejaculate at the sexual act contains mainly prostatic juice. The sperms or the spermatozoa, which are responsible for procreation, are a very small part, less than 0.1 or 0.2 ml. The remaining fluid is prostatic fluid, and that fluid nourishes the sperms until it reaches the egg and fertilizes it. So it has no role after you've finished your child productive age. It has no role whatsoever. The prostate has muscles in it. It's not just an inert potato. It has muscles in it. And when you ejaculate, the muscles contract and squeeze out the juice of the prostate. So when we want the prostate to empty out completely, the best way of doing it, rather than any prostatic massages, are for the patient to ejaculate any which way he can. Next slide, please. Now, these are the common conditions that ail a person with his prostate. Commonest are on the left-hand side, a benign enlargement of the prostate. Now, that is not even a disease. It is just a part of growing old. As you grow older than 60, the prostate invariably, now I use the word invariably, there isn't a person who has normal testes and normal testosterone whose prostate will not grow in size after the age of 60. Well, nevertheless, like cataract and gray hair, everybody gets them. But some people are able to see well unto their 75 and 78, and others will need a cataract surgery as early as 60. So that's why the complaints of an enlarged prostate may vary as to when they start. The second condition I wish to talk about is prostatitis. I may not have the time to talk about it today, but that's an infection of the prostate. It's common at any age, but generally occurs anywhere between 40s and 60s. The third and the most sinister of the lot is a cancer of the prostate. And we're going to talk about all these three conditions, least of all about prostatitis, because if I have the time, I will talk about that as well. Next slide, please. Let's talk about benign enlargement of the prostate, or an enlargement that everybody has. Now, aging men have problem with their urination. Next. They either pee too often, that's called frequency, or too immediately with an urgency, they cannot hold on to it, or too much waiting. That means they're there standing to pee and everybody else has peed and gone and he's still standing to start his pee stream. Next slide. Or incompletely. They feel at the end of passing urine, they haven't actually emptied their bladders. Next slide. Next slide. Or after going to sleep or at bedtime, we call that nocturia, or sometimes they dribbles in their pants after they've zipped up. That's called dribbling. Next slide. Or they cannot urinate at all. It's a full stop. This full stop may be painful or painless, and that's an emergency. Now let's go with the cascade of passing, what happens when the prostate is enlarged. On the diagram on the right, you can see a normal, happy, prostate, and you can see an unhappy bladder, a bladder which is blocked by an enlarged prostate. So, first slide. So the blockage of the outlet, what does it cause? Next slide. It causes the muscles of the bladder to contract more forcefully. And what happens? Because of that, because the forceful contraction of the muscles of the bladder, they become irritable. And you get frequency, you get urgency, and you have to get up at night. Next slide. The bladder then gets thickened. You can see on the right that this bladder has got thickened. And unlike the muscles of our body, like the biceps, etc., the thicker they are and the larger they are, they're better looking and better performing. But the bladder, once it starts getting thicker, gets weaker. That's a very important thing. So the detrusor starts hypofunctioning, the muscle of the bladder. Next slide. So that stage, you leave behind some urine in the bladder. You cannot overcome the heavy swing doors that are controlling the outlet of your bladder chamber. Okay, next slide. And then one fine day, either slowly, insidiously, or suddenly, the urine stops altogether and you have to be rushed to hospital for somebody to put a catheter in. Next slide, please. Now, in anything, very often say size matters, but in this case, size does not matter at all. The symptoms that you suffer from are completely independent of the size of your prostate. I have seen patients who have 150 grams of prostate. That's a humongous prostate, roughly the size of a tennis ball. And they have no complaints whatsoever. They're not even getting up once at night. And smaller prostates have a lot of problems. When we put a finger in the rectum to examine the prostate, next slide please, I do that to detect any hardness of the prostate or nodules in the prostate or asymmetry. I'm not bothered about the size. Next slide please. And similarly, when a sonography is done, we do it because it detects completeness of the emptying and the state of the kidneys like stones, etc. It's not done to see the size of the prostate. So Frequently, I have patients coming back to me and saying, Doc, last year my prostate was 35 grams and now today is 38 grams. Should I be doing something? Tear the report and throw it away. It has nothing to do with the reality of life. And the size of your prostate is, I'm not concerned with it at all. This is a questionnaire that we usually give patients so that they fill up and then we know what the symptoms are like. But I'll go to the symptoms on a more sort of one-on-one basis. Next slide, please. So there you are. These are the symptoms. I divide the symptoms onto two sides, the irritative symptoms, which are caused by the bladder, the muscles of the bladder, and the obstructive symptom, which is caused by the outlet or the gate. The gate is partially closed. So the bladder symptoms, they are frequency. Instead of going normally, we are able to hold on for at least 3 hours, maybe 4 hours. But when it starts happening and that you have to go within 2 hours or even less, that's frequency, that's worrisome. Urgency, when you find that you have to stop a conversation or stop your car in the middle of a journey and say, no, I need to take a pee stop, or you're getting up at nights more than once, at least 2 times or 3 times to pee, that's probably could indicate an enlarged prostate. On the other side, the obstruction. Commonly, we know that your urinary stream can pass a reasonable, not like it was when you were a young man, when you used to have pee contests and you try to pee over a wall, but at least your pee goes at least 2 to 3 feet away into the loo. When you find your stream is poor and your wife complains that the urine stream is dirtying the floor of her bathroom, or you find that you started it, you are aiming well into the toilet, but by the time you end, your stream is dripping down at the floor, or you find that you have to push a little to get the urine stream out. These are all symptoms which are worrisome. The last symptom is there on the side, and that is you feel you have not emptied your bladder. You feel that something is left behind. And often after you think you've emptied your bladder, you can go inside and pass a little more urine again. Next slide, please. So these are the symptoms. Now, very often in this time of COVID, my patients phone me up, Mr. Doc, is it necessary for me to come and have a physical examination? Can I now show you all the reports on the teleconsult? And the answer is yes, you can show me most of the results on teleconsult. What do I need to know? I need to know whether you're leaving behind urine in your bladder. For that, I can tell you, go and get a sonography done before and after peeing, and that'll give me a good idea. I don't need to examine you for that. I need to know what your foreskin and your meatus is the hole through which you pee, are like, particularly important for diabetic patients, but that not necessary. You can always do a snapshot with your phone camera and show it to me. You have a hernia, that you can either show me that there's a bulge, or you can do a sonography and that will show me the same thing. What I can't do is I can't do a digital rectal examination over the phone. So that there is no simple substitute for that. There is a complicated substitute, and that's an MRI, but there's no simple substitute for that. And there's a biomarker, which is called a serum PSA test, which you can always do at the lab. So all these things you can do. And if I feel it's necessary for me to examine you, then I'll call you, okay? What medical treatment? Now, generally people whom we think has an ordinary benign prostate, where there is no worry about the malignancy, and I'll come to the malignancy later, he needs treatment. And almost 70% of these people will do very well with medication, at least for anything up to 5 years, 10 years, or even more. So what is the medication we give people? We give medication. These are the 4 types of medications we give. There are plenty of drugs, and I'm not going to go into individual drugs. I'm going to talk only the main class of drugs. One type of drug is called an alpha blocker. The names you might have heard are Silodal, Weltam, Urimax. All old people have heard of these tablets, and many of you are probably on one of these. What these drugs do is relaxes the outlet of the bladder, so it opens out the outlet a bit, and your stream is able to pass a little more stronger. Your stream improves, emptying improves. The other is a hormone antagonist. This usually goes as a suffix of the letter F or D along with this, like Urimax D or Urimax F. The D stands for dutasteride, the F stands for finasteride. These are anti-hormones. The prostate and the hair on your head uses particular hormone called dihydrotestosterone. And if we block it, the prostate could be stopped from growing or could even regress a bit. Okay, so these drugs, alpha blockers, act only while you're giving them, while these drugs will keep on acting, so you have to take them for a longer period of time. The next drug is a drug called mirabegron or solifenacin. These drugs are there to curb the overactivity. As I said, more troublesome is frequency and urgency. Urgency is something that patients do not tolerate too well. A poor stream is something they don't mind. They'll stand longer and pee. But if it's urgent and you need to stop your car or stop talking to people in order to take a leak, that's very embarrassing. The last problem is often something that coexists with the urinary problem. It's a problem of, again, aging. As you grow older, your jackhammer doesn't function as well as it did when you were younger. So those are erectile problems. And we have something for that. And very often we combine that along with the urinary medication. Next slide, please. How long do I take these tablets? Common question I'm asked all the time. The first drug that are alpha blockers, Urimax, Silodil, they work only for 24 hours. You stop taking it, the next day your urine stream will be back to what it was. The anti-hormone drugs like dutasteride, they will not start working soon. They take a long time to start working. And if you want to see the effect of those drugs, you will need to take them continuously for at least 2 to 3 years. Bladder relaxant, you take them as long as you find this urgency. The moment the urgency is controlled, you can stop it. And the ED, if you want your sex life to continue, you take these drugs until such time as you think you or your partner are not interested in anymore. Next slide, please. Do you need surgery? Yes, when you've taken these medications and you're doing well, but then despite the medications, you're not doing too well. You're peeing with a very poor flow. You're getting up 3 times at night, and things are, what is most important we ask is that quality of life. Does it affect the quality of your life? Would you say that in any discussion regarding your health, the first thing that crops up is, my pee is bothering me? Then you need to get things rectified. Now, what do we rectify? What we do, this is your prostate that is enlarged, and we just carve out the inside of it. We don't remove the whole prostate. The rest of the prostate, which is the non-enlarged part, remains. So this is how you resect it. This is known as a resectoscope, and there's a loop. So we chisel out your prostate very much like your wife would chisel out a carrot to make gajar halwa. So, and the prostate comes out like gajar halwa. It doesn't come out in one piece, doesn't come out like a laddu. It comes out like halwa, okay? And your channel is clear and you pass urine very well. This is good for almost 90% of the patients. However, there are increasing number of patients who are on drugs called blood thinners. These are ecosprin, clopidogrel, and this is commonly given either because they have a stent or they have had a bypass or they have a cardiac disease. And these drugs, if they can be stopped for about 4 or 5 days, we can easily do this operation, the TURP, and so restart it within a day or 2 after the surgery. But if we cannot stop them because the cardiologist says, no ways you're going to stop my medication because the stent was put in just about 6 months ago, then we have to take recourse to another method of treatment, which is known as a green light laser. The advantage is that there's no bleeding at all, and therefore it's safer in a patient who is on blood thinning drugs. Next slide, please. The other problem that one can have is the prostate is humongously large. Even if they were 100 to 110 grams, this technique of TURP is quite satisfactory. But if you have a prostate which is 150 grams, 200 grams, 250 grams, these are humongous prostates, and they need something additional. So you could use a holmium laser which carves out the entire, almost like enucleates. When you say enucleates, means you take out the whole prostate like a laddu, push it into the bladder, and then morcellate it, make it into multiple, into chema and take out the chema. Next slide. Or you do an operation. No, please go back. Sorry. Or you do an operation which is very similar to the old operation we used to do, which is cutting open and putting your finger and taking out the whole laddu of the prostate. But you do it through a robot or laparoscopy, robotic laparoscopy, which makes it much more comfortable for the patient. Patient goes home in 2 days, has no pain whatsoever. And we've done the same thing. We remove the entire huge laddu without any problems. But these two have to be recourse to only when the TOR is not available, because TOR is perfectly satisfactory for nearly 90% of all cases. Now, we come to the dreaded subject, prostate cancer. Next slide, please. This is the normal prostate. This is the prostate of old people. You see that the gland is enlarged and pushed the remaining part of the prostate into the periphery. This is the cancer. It arises from the periphery and it's a little like a little nodule. This is usually harder than the rest of the prostate. That's why I put my finger up your backside to feel whether I can feel a hard nodule. That would make it suspicious for me. Next slide, please. What is this cancer? Next slide, please. Just a brief thing. It is a mutation of the cells in the prostate. Next slide. That usually arises from the peripheral zone, like I told you. Next slide. And it occurs as long as you have testosterone. Testosterone and prostate are linked together. For a person who's lost both, is like the eunuchs, which you see on the road, what we call the hijras, they will never get an enlarged prostate because they have no testosterone. Okay, the prostate epithelial cells produce PSA, and this is upregulated in a cancer. So you get the PSA gets elevated. PSA stands for prostate specific antigen. It is not a cancer specific antigen, it's only a prostate specific antigen. So anything that troubles the prostate, from a benign prostate, an infection or a cancer, will push up the PSA. And when we look at all the findings and we say, no, this PSA is worrisome, let's get an answer, okay? Are there any symptoms that will tell you, do I have a cancer prostate? The alarming answer is no, because the symptoms are absolutely the same as you would have with a benign prostate, no different. You have bad symptoms which are under that line, but those are only when the patient has an advanced cancer which has gone beyond the prostate and gone into his bones, where he starts getting bony pain, or into his nose where he gets swelling of the legs, or it's gone blocked his kidneys and he's got renal failure. So these are not complaints that we want to really catch you at. We want to catch you way before these things happen. Next slide, please. So how do we make a diagnosis of cancer prostate? The cancer prostate diagnosis revolves on these three, these inverted Mercedes-Benz sign. Digital rectal examination, most important, and I feel for a hard nodule on any one side or a hard nodule on both sides. I do a PSA, and the PSA, if it is high unequivocally, which means more than 10, I'm more worried. If it is equivocally high, which may be high, may not be high, then there are other things I can do. If it's unequivocally high and I enlarge and a suspicion on the DRE, I will do a biopsy of the prostate. Next slide. However, if the PSA is doubtful, or the digital examination, despite a high PSA, looks perfectly normal, then I might want some clarification. And for that, I use what is known as a magnetic resonance imaging. It's an expensive test, so we don't like to do it every so often. We do it when we have some difficulty or suspicion, and we finally do a biopsy. Next slide, please. A lot of my patients ask me, is early diagnosis possible? Of course it is possible. If I'm vigilant, I can do an early diagnosis. Next slide, please. Is it desirable? I would say yes. You cannot be an ostrich. You need to know if you have a cancer. But understand this, although prostate cancer is a relatively common thing, to die of cancer prostate is not all that common. Almost 60 to 70% of cancer prostates will go with the patient through life, and the patient may die with the cancer rather than of the cancer. So it's not a bad diagnosis at all. Is screening of the population desirable? No, which means I can't come into your office and say, okay, all you guys more than 60, come on, I'm going to do your PSAs, I'm going to put a finger up your backside. That's not done. Okay, we do it only in people who have a high risk. What is the high risk? In India, we don't have, the Africans have a high risk of cancer prostate. But in our situation, if you have an uncle, any paternal relative, an uncle or a brother, two of them who have had cancer prostate, then you should be screened, which means even at 45, you should get your PSA and have a prostate examined by a urologist. And if your PSA is plumb normal and your prostate is unenlarged, then you take a 2-year holiday and repeat that test. Okay? Okay, now once you've diagnosed, you did the biopsy and the biopsy said, sorry, sir, but you've got a cancer of the prostate. That biopsy will tell us what is the grade of the cancer prostate and give you a risk stratification, whether you have a very low risk, intermediate risk, or a high risk cancer prostate. The next thing we want to know is the cancer only in the prostate or has it gone beyond the prostate and gone anywhere else? To find that out, we do a test called the PSMA PET-CT. Now, we in India have been doing this test for the last 4 years. America, which is always slower because of its FDA regulation, has only gotten to this test this year. Can you believe that? We've beaten them. So we've done work on and presented our information on this scan for the last 4 years. America is still lagging behind. This scan is so accurate, it will tell us whether it's gone to the nodes, into the bones, or into the soft tissue. So we have a clear understanding of whether the cancer is only in the prostate or beyond. Next slide, please. So as I said, all cancers are not equal. You have to risk stratify them. So I can tell you, you have a very low risk cancer, intermediate risk cancer, or a high risk cancer. And that makes all the difference to your prognosis and how we hit you. Okay, next slide, please. The treatment, next slide. So the first order of business is knowing whether the cancer is only in your prostate. And there we treat you with curative intent. That means we're treating you as saying that we're trying to get you rid of this cancer forever. And you should be consider yourself cured if we succeed. Next. So what do? The cancer is limited to the prostate. Next. We do either radical surgery, which means we know the cancer is in the prostate, so we take the entire prostate and remove it and throw it out. Or we take the prostate and we burn it. When you say burn it, we use radiation to burn it. These are the two modalities available. Next slide. I will discuss the surgery first. There are two methods of doing surgery. One is open surgery, what we have been doing for the last 30 years. Understand this, that the prostate is a small gland tucked behind the bone of your pubic symphysis. That's the bone at the bottom of your abdomen. And to look at it, you can see both these guys banging their heads, trying to look inside into a very small wound, and you need long instruments. But ever since we've got robotic surgery, things have changed remarkably. Now here I am sitting at the console. My patient's lying remotely. My scrub nurse and assistant surgeons are standing next to it. They are only putting instruments in or out as I demand. And the entire surgery is done by me sitting on a console with instruments that have gone in with the robotic bedside console. You can see here my hands. I'm not washed up. I'm absolutely unwashed. I could have a cup of coffee next to me. And I'm using a kind of a joystick to manipulate the instruments inside. You can see me using the joystick here on this, on the bottom right of the slide. The instruments inside are what you call endo-wristed. That means they're like my wrists inside the abdomen. It's like putting small rat wrists inside and being able to manipulate them. So the next slide, please. So the advantages of doing robotic surgery are so tremendous that most of us who do cancer surgery for the prostate do not do it by any other method than the robot. We have 3D imaging, next slide. We have 10-fold magnification, next slide. Next, the movements as I showed you are 6 degrees of freedom. There's complete steadiness of the movement. There's no vibration at all. And the instrument, the movements are very similar to that they would be at open surgery. Next. And the movements are scalable. Next. This is radiation. If we consider the surgery is not optimal for you, or if you're too old to consider surgery, then radiation treatment may be a better option. Next slide. After surgery, we just look at the PSA and we gauge it. If the PSA remains undetectable after surgery or relatively low after radiation, then we think we have won the game. If it comes back, then we have lots of other medication. Next slide, please. For people where the cancer has gone beyond the prostate and has gone into there are a variety of hormonal and non-hormonal preparations. When you are at the early stage, we call it castrate-specific sensitive prostate cancer. Castrate sensitive, meaning that if you remove the testosterone from this patient's milieu, the cancer will immediately shrink. And that's what we usually do in the beginning for a person where the cancer has gone beyond the prostate. We give him either an injection every 3 months, or we do an operation where the testes are removed. Once the testosterone has been removed, there is complete settling down of the cancer until the cancer starts coming back. Then he's in a domain called CRPC, or castrate-resistant prostate cancer. Then you have the variety of other medications that we can give. There are too many medications for me to talk about, but essentially it means that when the disease has gone beyond the prostate, we first do hormonal manipulation, and then depending on the severity of the disease, we do a variety of other medications, including chemotherapy and a variety of hormones that will give treatment to the... How long have I been, Pradyum? I mean, how much time do I have?
You have been fairly long. We are at 5:35, so...
So you want to go on to the Q&A right now? Good. That's it. That's my last slide, actually. Yeah, that's Q&A.
Great. Thank you very much, Doc. I think you have, in many ways, addressed most of the questions that are there. But let me get out to the questions directly. We have a question from Milan Mehta, who asks, is it true that modern lifestyle has increased cases of prostate problems? If yes, what specific factors are to be avoided? That's question one. Question two is it true that food supplements like pumpkin seeds, etc., are useful for avoiding prostate problems? Which are the foods which are useful?
The answer to both these questions on an evidence-based matter is no to both. There is nothing, prostate diseases have not increased because of the change of lifestyle. As a matter of fact, if you look historically, prostate enlargements were there in Shushruth's time. And bladder stones were very common in old people. And Shushruth was the first person, we're talking of, when, 600 BC. And Shushruth, one of the first person who devised operations to remove large stones from the bladder, which were caused by an enlarged prostate. Okay, so enlarged prostate occurred from time immemorial. There is nothing, pumpkin seeds, chia seeds.
We have a question from Ajay Khare, who says, Doctor, this question is on urgency. There are weeks and weeks, there's no problem, but there are times when urgency is acute and therefore distressing. USG indicates that bladder emptying is not an issue. What steps do I need to follow?
Very, very good question. This is a genuine, you've done it perfectly. Your urgency is due to overactivity of your bladder. That may be urgency because the bladder is overactive by itself, de novo, nothing to do with your enlarged prostate, or it might be due to your prostate. First things first, you have to change your lifestyle. And that is, you'd stop or reduce the amount of tea, coffee, and colas. They are the most irritating to your bladder, and that gives you a lot of urgency. If you have never had urgency and you suddenly got urgency, check your urine. You may have an infection, and that may be the cause of urgency. If all these are normal, then you've got medications, which I spoke about in my slide, which can reduce your urgency because we don't know what the cause is. Men and women will get what we call OAB, overactive bladder. Women don't have prostates, but they also have a severe problem of urgency, so severe that they refuse to drink anything for hours before they leave the house for any function at all. So that kind of problem can occur. We usually treat them with behavioral treatment, like reducing the amount of water they drink, stopping their tea and coffee, and finally using medication if required.
Another question from Milan Mehta, who asks, nowadays, how many hours later or days later is a patient discharged after a prostate operation?
2 days in the hospital after your TUR. Third day morning, you're home. On the evening of your TUR, that's an ordinary TUR surgery, you will be passing urine perfectly. I mean, your urine will be clear in your catheter, but we choose not to take out the catheter next day. We take it out the third day morning. So you stay 2 nights following the surgery. That's all. If you do a laser surgery, you could stay only one night. But there is no great advantage. Remember, laser is no better than TUR. It's a lot slower, and therefore there is a possibility of incompleteness of the job. But laser needs to be resorted to if there are conditions where you cannot use an electric current. Like as I said, if you have blood thinning products, or the other thing is if you have a pacemaker of some sort. Nowadays, all the pacemakers are actually current safe. But if you have a pacemaker, on increasingly new thing is deep brain stimulator. People with Parkinson's have a deep brain stimulator in their cranium. That's a very expensive piece of equipment. And if we choose not to use current, because that might, upset the implant.
The second question from Dinesh Taparia was, can you explain about kidney stones? How do they happen? What are the precautions that one should take with regards to diet? And is it a hereditary issue or diet related?
It's a bit of both. It's nature and nurture, both. So the urine is a reflection of what you put into your mouth. So it depends. Urine is a solution. It has water, that like any other solution has water and solutes in the solution. What you put in your mouth will be the solutes that go into solution, and the water you put into your mouth will be the liquid. If you have a very dilute, now you've done experiments in childhood where you put a glass and you put sugar in it till the crystals come out. You keep on adding sugar, then the crystals form on the thread or whatever you put in the glass. So if you have a concentrated solution, you will get crystals. So if you are a poor drinker of water and your urine is concentrated rather than very dilute, the chances of forming a stone are higher. Doesn't mean inevitable, are higher. Yet many people will say, I hardly drink any water. I've never formed a stone in my life. The reason for that is we have inherent in us what we call stone inhibiting factors. There are factors that allow the crystals to pass out in the urine without allowing them to aggregate and form a stone. One of the common things that causes aggregation of stone are uric acid in the urine, which acts as a scaffolding for stones to form. So commonly when a person forms stone, I tell him stop or reduce the amount of proteins you eat. If you are a meat eater, if you're a fish eater, then reduce the meat and fish that you have. And second, reduce your salt. And he said, no, doc, but I've been told don't have calcium, don't have milk, don't have dahi, don't have chicken. No, that's not all that important unless you're a milksop and you're having 3 glasses of milk a day. If you're having just milk in your tea and coffee, that's unimportant. And calcium does not actually increase unless it's a high amount of calcium or it's calcium given therapeutically, like women who are post-menopausal are taking 2 tablets of calcium and vitamin D to prevent the osteoporosis. There they can form stones, particularly because women also have reduced their water intake because of the same thing I told you earlier. Overactive bladder, water intake has gone down, they're taking calcium supplements, they're taking vitamin D, and they come back with small stones. So yes, you can reduce stone formation mainly by drinking in excess of 2.5 to 3 liters, and 2, by reducing the protein intake and reducing the salt intake. If you are taking a large amount of calcium or therapeutic calcium, then you should reduce that or increase the water intake. I hope that answers this question.
Thanks. We have a question from Mr. N. Ravindranath. He is aged 73 years. Some of it you've already answered, but let's take his specific issue. At night, especially during rainy days, he wakes up 2 or 3 times for urination. Other normal days, only once. Is it due to a prostate problem? Also, for normal healthy person, what is the PSA index? How do you get this figure? He also says, I used to take a lot of water. What is the minimum available urine in the bladder after one is urinating? Completely empty bladder, is it possible?
Yeah. Good questions. 3 questions now. The first question was, sorry.
The first question was that, on rainy days, he wakes
Yeah,
up.
of course. Now that happens with everybody. A lot of my patients, this is a common thing, the battle of the sexes. The wife wants the AC, the husband finds that if the AC is on, he's going to the loo frequently. So he doesn't want the AC. Cold always encourages your urination. So if you find a cold environment, particularly either in the AC or a direct draft of the AC onto your body, then you will find you're urinating more frequently. Nothing wrong with that. Either don't put the draft directly on yourself or put off the AC after the first hour once you've gone off to bed. So put it on timer to put the AC off. That answers the first question. The second question was,
what is the normal PSA index? And
the PSA, yes, that's a very good question. Now, this is done by doing a survey among a large body of people, a population survey. Such a population survey has not been done on the subcontinent of India. So we are relying on a European population survey, which says that 4 nanograms per deciliter is, up till that is normal. Between 4 and 10 is considered as borderline. More than 10 is really suspicious. So that is what is available to us. We have to take that under, as I told you, PSA is prostate specific, not cancer specific. So if there are other reasons, for example, if a man came to me with urinary burning, urgency, has few pus cells in his urine, and has got a PSA of 15, I'm not going to panic. I'm not going to do a biopsy. I'll just give him antibiotics, come back after 3 weeks and see your PSA again. The PSA has gone down to less than 4. So it shows the infection that caused the PSA to rise. But the ballpark figure is 4. Anything more than 4 gets our antennas up. Anything more than 10 gets us a bit panicky. Okay.
We have a question from Bridge Duggal who asks, I'm taking Diator twice a day. I get up at night after 2 hours. Is it okay?
Diator, because you're taking Diator, you're producing more urine. Now, a lot of people get up in the night, not because they have a prostate, but because they're producing more urine. Firstly, after you cross a certain age, you produce more urine at night. The proof of that is go to any geriatric wards where you find all these old biddies and old Buddhas who are lying down with catheters in their bladder. You'll find the bags are full overnight and they're not so full during the day. That's because there is a reversal of the diurnal rhythm. They pass urine more at night. To make matters worse, diabetics produce more urine at night also. And the other thing is, if you are slightly plump or moderately plump or morbidly obese, then you have a definite problem of passing urine more frequently because it's related to sleep apnea, obstructive sleep apnea. Many of my patients who have obstructive sleep apnea because of being quite obese, when they're put on a breathing machine, a CPAP or a BiPAP machine, they find that the frequency suddenly reduces down to come down to perfectly normal. And so how did that happen? I put a ventilator on my mouth and now my urinary frequency is down to normal. Because it's all related. Even the other thing is obesity is a great enemy of almost anything, including likelihood of cancer, likelihood of heart disease, likelihood of so many things, including likelihood of urinary problems. So, because obesity is generally linked these days to what we call metabolic syndrome or insulin resistance. I won't go into details of that, but that should answer that question.
Doc, we have so many questions, but I'm going to just stop at the last one, which is from somebody who's Mr. R. Gurnani, who's 83 years old.
Wow.
I have an enlarged prostate problem since 15 years. I'm under treatment of Dr. Spiros Sunawala.
Wonderful.
I'm taking Aftura tablet every day after breakfast. My problem is I go to bathroom 4 to 5 times every night. The doctor said he can reduce the frequency by giving some other tablet, advised me not to take any medication. I consume water approximately 1 liter a day. He advised consume water by afternoon, don't consume more water late evening. If I drink less than 1 liter, no problem. I'm a sportsman. My age is 83. Any suggestion?
Wonderful. God bless you, sir. God bless you. I think that all the advice you could have had have been given to you by my friend Feroz, and very aptly so. The thing I would encourage you to do is after 5 p.m., no tea or coffee. Absolutely important. No tea or coffee after 5 p.m. Reduce your fluid intake after 5 p.m. Have a dryish dinner, an early dryish dinner. When I say dry, do not have chas, lassi, soup, or any other liquid preparation with your dinner. And do not exceed an intake of 2 liters in the whole day. That all these things should be enough. If they solve your problem, do not add any medication. If despite this you still have a problem at night and it's a worry, if you say it's no worry, I get up twice, I go to bed soon after that, and I'm not bothered, then it's fine. But if it is a worry, if it makes the next day troublesome, then take a tablet. We can give you something and you can reduce your night frequency.
Doctor, there are so many questions that are there. We've got questions from PRS Rampalli, whose name I never get right, Ashok Agarwal, Naveen Podar, Vijay Patwa, Ajit Menon.
All these people can, if they wish, write to me on my email address. I don't promise that I'll reply promptly, but if when I get the time over the weekend, I'll reply to all their questions.
Yeah, and Doc, one more question that has come in, and how do we teleconsult you, Doc?
Right. I teleconsult both at Jaslok and at the Reliance. If you phone either of these hospitals and ask for a teleconsult, it can be done. I would rather take the decision of doing an in-person consultation myself. If I think it is important after the teleconsult that I should see you in person, then I will call you at an opportune time. Obviously, if I see you, I take the responsibility to safeguard your health in these COVID times, and you should rest assured that I'm not putting you at any additional risk.
Thank you, Doc. Lovely presentation. I'm sorry to our to people here that we've not really had too much time for questions, but I think the presentation in many ways addressed most questions that people would have had. Thank you very much, Dr. Chibber, for for spending time with us and for our readers of Seniors Today.
My pleasure. Entirely my pleasure. Thank you very much.